Well, hello again. It's Jason Renault with the Alternative Mobile Services Association and AMSA Talks. Today we're talking to Morgan Shields of Washington University at St. Louis. Welcome, Morgan.
Hi, it's a pleasure to be here.
Morgan, you've published with some colleagues a very interesting article, and it's in JAMA's Open Network, so everybody can see it. It's going to be in today's AMSA newsletter, so you'll see it linked directly below the video you're watching, but it's on public attitudes towards mental health treatment policy.
hmm
And you'll have to open that up for us. But before you do, before we talk about your article, tell us a little bit about you and how you got into this field of research.
Sure, I'm happy to. So I am an assistant professor at WashU School of Public Health. And I like to say briefly that I study quality and accountability of behavioral health services broadly. But most of my research has been really focused on the setting of inpatient psychiatric care. What do we know about quality? How does it vary across different types of organizations and people? What are the data gaps? And what are some of the policy levers that might help to improve quality and specifically the patient experience? Um, Through that work, I've been sort of more and more convinced that we need more options when it comes to crisis services that extend beyond the hospital. And so that has become a increasing interest of mine, which is alternatives like peer respites, et cetera. Um, when are those appropriate? What are the sort of the core features? Um, how might we think about scalability and sustainability? So those are some of my current questions, as well as trust. So I have a line of research focused on trust and crisis services, thinking about what are sort of those core values that underpin trust, how would we operationalize them, um, at all levels, at the ecological level, so interpersonally, at the organization, and at the systems and societal levels. And then just briefly about some of my background that brought me to this line of research. I grew up with a father who um, was diagnosed with bipolar, and actually was quite impacted by his condition. He would be manic for 2 years at a time, would be depressed for 2 years at a time, um, and found it really challenging to work, and often was in and out of jail and refused to take medication. Not always, but that was sort of a challenge, and was deathly afraid of the hospital and actually much preferred going to jail than the hospital. And so I have um, this lived experience as a family member from when I was really young, pretty intense lived experience of seeing my father really struggle,
Mm.
um, and really wanting to be able to send him to the hospital. Actually, my mom was really frustrated by all of the rights that people have, and that my father knew how to perform, and she wished that it would be easier to force him to take medication. Um, and then I had my own lived experience, which sort of shifted some of my views on this. And I will just say I think it's challenging for someone to sometimes adopt a more critical lens of the hospital without having embodied the experience themselves, because it is so, I will just say from my experience, it was so counterintuitive to what you would hope a psychiatric hospital experience would be. You would hope that this would be a workforce that would be skilled in human connection, and de-escalation, but it was sort of the opposite. So I had a series of really, really traumatizing um, encounters with inpatient psych during moments of mania, myself, when I was young. And so that's sort of the foundation for me, that has informed my trajectory. And then I would say now I've sort of learned so much about the system. I've done my own research, and my views of inpatient psych have actually become, in some ways, much more critical than they were when I was younger. um, uh, which is just due to what I have learned at a systems level.
So I often hear people having opinions about hospitals, psychiatric hospitals, but you actually have personal experience, research experience, work experience, education. You actually know what you're talking about.
Yes, I'll say that. Well, it's interesting you
Great.
say I both know what I'm talking about and I don't know what I'm talking about because one of the things I know, what I feel very confident in saying, is that we actually um, don't have good data on inpatient psych. So actually, our knowledge on what's happening inside of these hospitals and how it varies, just sort of I mentioned at the beginning, is quite limited. And that is, when you think about how vulnerable the patient population is in so many ways, um, and then you think about how little information we have. There's a lack of observability. Um, Regulations don't necessarily seem to always be enforced. There's been increasing investment by for-profit corporations. It should all be quite unnerving for us, actually. Um, and, we should be concerned about potential harm to folks in these facilities, and we have no way of knowing what's happening to them. And certainly, we have a lot of testimony from people and their lived experience. And throughout my research, yes, I have my own experience, but I've come to realize that my experiences are not actually that unique. And that is really a concern. I started off this research wanting to understand, you know, variation in quality and why there are some of these places that can be really, really bad. And I've come to realize that it's some of these really bad experiences people have are actually quite normative. And then I've come to learn that we lack any evidence that inpatient psychiatric care is beneficial at the population level. And that is shocking because we use it. It's so ubiquitous and we debate whether or not we should force people into the hospital or not. But we have no evidence that it's beneficial, and that's really wild. It's one of the only times when your civil liberties can be infringed upon without committing a crime. Um, so, and there might be disagreements on the value of forcing a person when they might need, help into treatment. But one thing I'll just say is whether or not you force a person or not, whether or not it's voluntary or involuntary, if the services themselves are degrading, they're dehumanizing, they're sort of terrorizing a person, making their own terror worse, it's not therapeutic. So that's where I think perhaps across different advocacy camps we could maybe come to agreement. You know, the role of force is something that to be debated. But then there's all right, but shouldn't we all agree that no matter what, the services should prioritize human connection and trust building? So,
Well, this is really getting very complicated very quickly. Let's loop it
sorry.
back to, that's okay. We're going to dig in here. Let's loop it back to mobile crisis. And our workers are out there in the field, seeing people in various states of crisis. Sometimes they're psychiatric, sometimes they're not. Sometimes the obvious destination to the team is hospital.
Mhm.
Uh, how should people be thinking about that who are on mobile crisis teams, that the obvious destination is hospital?
It's a tough question because there's sort of, on one hand, the question about what should the world look like in general. And then there's
Mhm.
the question of, okay, given our current world, what should we do with our options? And there are slightly different conversations to be had. Um, I think that something to consider is that for a lot of people, the hospital is experienced as I mentioned, dehumanizing, um, cold, scary. Um, some people do find some benefit from the hospital, but some people report that their experience made them feel worse, made them want to kill themselves,
Hmm.
made them never want to reach out for help again or to honestly disclose their inner thoughts. And so the decision to take someone to the hospital or not is a very serious decision. And I think that's how it should be considered, that it is very serious and there's a lot of risks. I think that sometimes when we talk about the hospital, we talk about it more in terms of it being a benign or a benevolent intervention. But the reality is that it actually can be quite harmful. And so we think about how could it be harmful? Some mechanisms are, I've mentioned sort of the interpersonal, the dehumanizing aspect, feeling like you're in prison, not having information shared to you. These are sort of like the environment or the culture of the facility and the way people treat you on a regular basis, whether or not they ask you questions, you're able to participate in your care. That's one mechanism, right? And for people who are being hospitalized for mental health reasons, it is reasonable to expect that relationships would be at the center of what might help as well as what might harm a person. Even for people in psychosis, they're afraid they're going to be hurt, they're going to be poisoned. So even more reason to try and patiently build trust. Um, and so there's the interpersonal. There's also the role of medications. So, yes, for some people, medications might be what is needed. What happens in these facilities often is it's not necessarily personalized, and there can be an irresponsibility with the meds. Uh, and even with thoughtfulness, people are taken off meds and they're put on new meds and then they're discharged without observing what's happening to them. That in and of itself can be quite disruptive, and could be one of the mechanisms that explains the really high rates of suicide following discharge from inpatient psych. It's the highest risk period. So there's the medications. There's also the disruption to a person's life. So you're taking them out of the community, and there's probably going to be consequences for a lot of people. If they're employed, they may lose their job, which could have cascading consequences. Probably not good for their mental health. Um, there could be consequences to relationships, um, and or schooling and education. That's sort of been an issue in this country is students in crisis have been pressured to drop out of their universities if they've gone to inpatient psych. Um, so there's this discrimination component. So, I mean, those are a few of the mechanisms we might think about. And it's actually, there's also the risk of physical harm, and not just from other patients, but from staff. They use restraint and seclusion. Um, and there have been a number of incidents of people dying due to over medication, for example. So um, it's to say that it is a very serious intervention. We don't know a lot about its benefits. We know that there's a lot of risk. It's a really hard thing to study. And so the decision to take a person to the hospital it's a pretty serious one, and should be considered in that way. And I think no matter what, relationship building um, and connecting with a person should be paramount. Um, yeah.
Okay, that's very good. It tells me a lot about the prospective harms that hospitalization could do to an individual. Now let's walk through your article a little bit. But
Yes.
as we start with that, would you tell me a little bit about your co-authors?
Yes. So I have three co-authors, Dr. Nev Jones, who's an associate professor at the University of Pittsburgh in their social work school. And Nev is a leading scholar on a range of topics, actually, but including lived experience inclusion, um, crisis services, the experiences of service users, among a range of other topics. And then Shyamal Sharma is a research fellow at Brandeis University's Heller School for Social Policy and Management. And she's had a career in conducting healthcare services and policy research. She has not done much on this topic, but she actually reached out to me with interest in the topic. And so Nev and I involved her in the development of the survey. And then Dr. Susan Busch is at the Yale School of Public Health, and she is a mental health economist. And so she's interested in these questions, these policy questions, but as well as the broader economics of behavioral health care.
So we've been hearing from some politicians who are currently running for office that hospitalization is the solution to many urban blights,
Mm,
mental illness, homelessness, drug addiction, maybe crime. Uh, the pendulum seems to be swinging, and this is part of your article, toward a more authoritarian institutional solution. The costs of this are never discussed, but I mean, the logistics are also impossible. But, what are these people really talking about? Who are they talking to?
mm. That's a good question on who they are talking to. I would imagine who they're talking to are people who probably are feeling unsafe. And so they might be speaking to people who would love really quick and easy solutions to the discomfort that comes from living among people who are experiencing hardship and poverty and homelessness. Um, and and that includes maybe business owners who do are impacted by people sleeping on the streets around their businesses, certainly. So that's probably who they're speaking to. You're right in that it is financially and logistically a challenging, approach to trying to solve those problems, as well as a, a, um, a morally questionable approach as well. Um, and not necessarily appropriate because we know that the majority of people experiencing homelessness actually don't have mental illness. Um, we know that the number one cause of homelessness is lack of affordable housing. Um, and for folks who are experiencing mental illness or substance use, we know that supported housing first models are effective for them. So, get them into housing, wrap them around with supports. Don't abandon them, of course, but that is probably going to lead to better outcomes and will be more cost efficient than sticking them into an institution.
Cost of state hospital out in my state is about $500,000 a year.
Wow.
There's probably civil commitment criteria. I don't know, 10,000 people eligible for that. You can do the math. It's just not, but people are running campaigns on this now. And
Hmm.
so where does this fall in the Democrat Republican? And we'll put up on the screen your chart here of your graph showing some actual data that you've collected.
So, one thing I'll point out before we get to the actual data from our survey is that these policies have been endorsed by both Republicans and Democrats. So it's been California and New York that have really been leading the charge with trying to expand the use of both hospitals as well as uh, forced, outpatient services, assisted outpatient treatment. Um, and I think that if we think about the attitudes or the values, if we think about the values that underpin those positions, they're probably multidimensional. And for some people, it might be coming from a place of benevolence. They see people that are in need and that this is their approach to helping them. They think we need more hospitals. And it is quite a simple thinking, but that it comes maybe from a place of benevolence. And for others, it maybe comes from a place of um, fear, annoyance, um, perhaps from a place where there's a bit more, well, I'll just leave it at that. So, in terms of our survey, what we did was we realized there's actually quite a lot of research on this concept of stigma There's different forms of stigma, and there's this research, and often the researchers use what's called a vignette, where they describe sort of a character of a person, and then they ask people, what do you think should happen to them? And sometimes the
Hmm.
questions are about the use of coercion. And so there's some research on attitudes towards the use of coercion in these very specific instances, um, with these characters. But there's been no research to describe, in general, at a high level, do you think that policies regarding forced interventions should be expanded? 'Cause that's really the debate here, right? Like, one of the debates is, should we expand the criteria for forced inpatient treatments
Mhm.
to be medical necessity, which is broader and really gives a lot of power to providers, and it's their discretion. If they think someone is not taking their meds, they could say this is a medical necessity. It's broad, and it's and which necessarily limits the rights of service users or patients. That's sort of the push and pull here. Versus, in a lot of states, the criteria is a bit more restrictive, and it's anchored around dangerousness. Are they an immediate risk to themselves or others? So that's a bit more narrow. Or the use of outpatient services. And so we wanted to just ask simply, do you think that, we should expand these sets of policies at a high level, thinking about blunt policy changes? So we asked about expanding access to community-based mental health care services. Should that it be expanded? Um, Expand policies that increase access to peer-led services.
Hmm.
Um, and for that, we did define what peer-led means.
Mhm.
Not everyone knows. And then we have the coercive policies, which is make it easier to force a person to take psychiatric meds against their will, make it easier to force a person into the hospital for psychiatric treatment against their will for short-term care. And then again, for long-term care, we asked that separately. And then make it easier to force a person with substance use disorder to receive treatment against their will. So if you are someone who's sympathetic to this argument that it's so hard to you know get convince a person to get treatment, and that one of the major issues, is that people are refusing treatment, and so we have to force them. You might say yes to this, that you agree that we should expand some of these policies. What we found is that about 73% of the public, this is a nationally representative sample, supports expanding access to community-based mental health care, and about 65% support expanding access to peer-led services, which is actually quite impressive.
Very good.
And there's no differences between Republicans and Democrats. So on those two items, there's bipartisan support, which is exciting. This is among the general public. It's not among politicians, right? When it comes to coercive policies, there's a lot less support, but still some sizable support. So about 40% of people support expanding the use of forced medications.
Mhm.
About 45% support expanding the use of inpatient psych for short-term care, and 42% support expanding it for long-term care, and 53% support forced substance use treatment, which actually, that is, so there's sort of a gap between more of the psychiatric versus substance use, and that's consistent with some of the stigma literature that shows that there's a bit more um, bias or stigma towards people with substance use disorders than people with mental illness, which is interesting. For all of those, in our unadjusted analyses, there is generally no difference between Democrats or Republicans. But then in our adjusted analyses, we did see that Republicans were more supportive of uh, forced inpatient care for short and long-term stay and forced substance use treatment, but still no differences in expanding community-based or peer-led services.
Well, this seems to be very high numbers just to acknowledge that these things exist. What do you ascribe the difference in political parties?
Um, the differences in uh, the forced items
Hmm.
between
Hmm.
Republicans and
Where you see
Democrats.
the larger variants, such as forcing a person to be hospitalized in a psychiatric facility.
Yes, it's interesting. So it's interesting when you consider that historically Republicans have been the party of less government intervention
Mm.
and liberty, a bit more than the Democrats.
Hmm.
And so it is interesting that that doesn't translate um, to this issue or this population. And I think this could be due to a difference in the way they are conceptualizing this part of our population compared to themselves, that there might be more distancing potentially. I mean, these are sort of empirical questions one could
Hmm.
ask.
Hmm.
Um, they might have more of a pull yourself up by your bootstraps mentality, perhaps, that translates into a harsher view on what should happen to people who are struggling, which then might transfer to support for these sorts of forced interventions, like just, um, force them into the hospital, put them on meds. It's slightly a dehumanizing approach, and it's a dehumanizing mechanism, maybe underpinning it. And then I mentioned with the substance use that I think that in particular, folks are seen as being responsible for their addiction and their challenges. And so there's less compassion. We see that in research when it comes to folks with substance use disorders than um, people with might have diagnoses of mental illness or mental health conditions. And then there's also, there's the national rhetoric. But one point I want to make about our data is that we moved very quickly because we wanted to get baseline estimates before the Trump administration did anything.
Hmm.
Because our thinking was that the Trump administration was going to affect public attitudes
Yeah.
through messaging. And so these data were collected in January and a little bit in the beginning of February.
Hmm.
And certainly he did messaging through his campaign, but the messaging is really picked up later in the year, right? So it's possible that these attitudes have shifted and there could be a bigger divergence between Republicans and Democrats now than there was in January. And that is, that's something we would want to do is to redo this survey potentially soon and
Hmm.
then, in a year or two and kind of see how the trends change over time.
Yeah, this recording is being made on September 24th, 2024, and I want to note to the viewers and readers of the newsletter that we'll be linking to SAMHSA's newly released strategic priorities right underneath this recording. Uh, they are a little convoluted and a little confused, not surprising, considering that a lot of people at SAMHSA have left. But we do see those policies changing quite rapidly and reflecting really real political goals more than clinical goals.
Mm,
Can
yes,
I ask a
thanks for
little bit
sharing that.
about if you had some thoughts about what this survey might have looked like if you had taken it several years ago?
Um, yes, that's a good question. I, well, one of the reasons I wanted to put together this survey was I very much remembered in 2016, 2017, when Trump was president originally, his rhetoric around um, people in mental institutions.
Hmm.
He uses that language a lot uh, in an awful way, to be frank. Like it's awful. And even back then supported after school shootings, for example, he would make comments about how we need to make it easier to civilly commit people. Just these very flippant comments. And so it definitely was in the air from him in terms of his messaging, not as profound as current. So I don't know. It's possible that if this were a few years ago, um, maybe uh, we would see less support for forced interventions. But to be honest, I'm not even convinced of that. this has been an ongoing debate in this country. And like I mentioned, for a lot of people, it does come from a place of benevolence. A lot of family members who've been impacted by mental health crises, for example, are quite sympathetic to figuring out how to expand forced interventions. And it doesn't necessarily fit across, party lines.
So hospitals are hard to build, hard to staff, hard to fund. What should communities be looking at as alternatives to hospitalization? You mentioned some of these in your introduction.
Yes, I think that, well, there's sort of a range of categories we can think of. If we want to think about a category of a place where people can go, which for some people that is quite beneficial, then alternative models that are not a hospital, which could include like a home-like environment, like a house in the community. Um, that is, one model is pure respites, which are staffed entirely by people with lived experience. A drawback to that model is that they tend not to um, deal much with medications, for example. So someone who might feel that medications is actually what they need, um, that may or may not be a good fit for them. But we might imagine more of mixed models, and there has been a history in this country of maybe a more professional workforce within a home-like environment, like the Sotera model. That's an example, which currently exists, I believe, in Vermont. I might be getting my state wrong. And then I think they're opening a new one in New Mexico. So Sotera is and they've historically really specialized in psychosis, but it's home like. It's very um, focused on choice and autonomy, and relationships. And they use meds maybe, but they try to minimize it. So there's not this overemphasis on the meds, and there's more emphasis on making meaning of one's psychosis and human connection. And and then um, and then you could think about another category, which is going to someone's home, because
Home
not
care.
everyone, yes, not everyone wants to leave their home. And for some people also, yes, they're in crisis, but they might be able to manage it if they had someone with them, a companion, who can just make sure, right? Like they're not, you know, spending too much, especially if there was like a consent process to this, um, uh, especially beforehand. But like, you know, a companion model or like open dialogue where you bring a team to one's house and you involve everyone living in the house, which again is all of these at their core are about relationships and building trust. That's sort of what I would say is when we're thinking about what the alternatives are, we have to be thinking about, okay, at the core of it is building trust and relationships. And what are those options? Um, and then there is, meeting people in the community wherever they're at because they may not have a home. And I think that gets a little bit more complicated in part because there is this added consideration in terms of public safety it's a bit more apparent sometimes when a person is unhoused than when they're housed. It just becomes more of a because their house is in the public essentially, their home. So so but yes, those are some examples. It's not to say, hey, I think we should scale up peer respites and everyone in crisis should go to a peer respite, but that it should be an option. And for some people, it might be a terrific fit. It shouldn't be the only option, in the same way that the hospital really shouldn't be the only option. And currently, for most people, is the only option.
Hmm. Well, thank you. Thank you for your work, Dr. Shields, Morgan, and thank you for talking to us
Thank
today.
you, Jason. Thanks for having me. Appreciate it.